Details in treatment, the schizobsessive situations. In our daily implementation, as all of us encounter these situations which are quite challenging when they come to us. If we could start the slides. And this is the title. Actually, the contents, the part about treatment is going to be rather fine. So after giving you some information and data, I will try to interpret what we can do in the end. For over 100 years, discussions have been going on this subject in psychiatry. Westphal in 1878, obsession and schizophrenia, he stated, were just two separate pictures. But in our daily practice today, these two syndromes are integrated, and many people impose this argument. Stengel, for example, in the fourth center, which is says, and obsessive, simultaneously interpreted psychotic patients and psychotic ideas are illogical, and they are able to conceive that. This was the outcome of a survey after which this statement was delivered. So we have to be very careful on this process, starting with Freud and other men of literature in concerning obsessional situations and schizophrenia were very related, and hypothesis was that this is stated as a protective mechanism related to the patient's psychosis during adulthood, and there are lots of obsessions that we encounter in such cases, and then the first episode is apparent. Naturally, both definitions, we have certain parameters as proof. Now, we have to assess these both definitions at the same time. In schizophrenic patients, in about 10, 15 to 20 degrees, we can observe obsessional syndromes. Naturally, the results, the outcome of studies can be different. The Yale-Brown obsessive-compulsive scale is used. In some others, like SCIDS, other structured scales are used. And these are one of the most important reasons for the symptoms. Craig and colleagues, ever since Freud, what obsessions and whether they are a protective factor against psychosis. In the first episodes of schizophrenic patients, when it was assessed after 2 years, the rate is reduced by 1/3. Perhaps leaving schizophrenia, the picture that is apparent goes deeper into other fields of psychosis. When we assess the whole thing, the syndrome, levels of syndrome, 10 to 12% and reaching 26% for definition. So regardless of how you approach is the relationships or comorbid processes in schizophrenia and obsessive-compulsive disorders are important. So, schizophrenia and what is the share, but it's not easy because there are certain indications of obsessive-compulsive disturbance or disorder is not reached. What are we going to consider? For example, in that also we can observe whether there are changes, and from normal thinking to excited situation, we can consider the comorbid situations when we think about obsessive compulsive disorders. There are some few important and good points. Actually, in many sense, they can exhibit certain indications similar to schizophrenia, and in OCD as well. In many studies based on this, usually there is a more frequently observed disturbance of identity. In obsessive-compulsive disorders, which accompany schizophrenia, it's a more disturbing process for the patient and reduces functions. Early starting of age, more fails. Obsessive-compulsive disorders, and it's not a pure syndrome, but the clinical situation appears as a result. Another result is that in OCD, in their images, the orbitofrontal cortex has more lesions and increase of activity. The dorsolateral cortex is assessed as the region for schizophrenia, and also dorsolateral and frontal cortex are regions where there are results of studies that are present and are proof. So we believe that it is clinically exhibited. And also there have been proven therapies, but we don't get a good response. Perhaps this is the most important under normal conditions. If there is resistance to OCD, low dose atypical psychotics can be beneficial when we add that. And schizophrenic behavior disturbances, disorders exist. The clinical characteristics or features are that in the obsessive-compulsive process, that insight is not satisfactory. From the schizophrenic aspect, the existence of OCD makes treatment more difficult. So more psychotic indications can insist, and worse cognitive or performance is exhibited in tests. But in 2005, Unger and Goff, for example, carried out a study, but with the neuropsychological tests, no difference is seen. And in 2008, another study that was carried out during the less energy is more severe depression, and also recognition of more anxiety disturbance, which is accompanying, and the paranoid symptoms are higher, and the first-line symptoms are more frequent. And accompanying obsession compulsion, there are other important matters, but it does not create a meaningful difference in overcoming or destroying competence. And interpretation is that it might not be seen at all times as wholly destructive. In the OCD, usually 10 to 15% of the patients are not psychologically sufficiently assessed. In 1945, for example, in 2007, Poires and colleagues pointed out Einstein's obsessive patients, obsessive-compulsive indications, show that there is a sufficient içgörü.
Self-awareness
that there is insight and awareness up to 85%. And another dimension made up from the focal points of schizophrenia, a subgroup can come out. Another link in this chain is the neuropsychological assessment. And also in imaging we know which regions are activated. When we accompany that with neuropsychological tests, then this becomes a better study. I'd like to give you 4 examples. These are Turkish individuals. Öngör and Goff, for example, carried out a study. The Yale-Brown obsessive-compulsive scale was used and separated into 3 groups. They also had a very comprehensive neuropsychological test. The results of the test do not differ. And these were stable patients from the point of view of schizophrenia. So that is why it's different. Our conclusions are different from other similar tests. This was indeed a different study. But in studies carried out from Turkey, Aydın Menderes from Adnan Menderes University, for example, carried out a study that was highly recognized in schizophrenias with OCD and pure OCD patients, together with healthy controls, were assessed with a neurological assessment scale. In the subgroups, certain differences were observed and determined. In obsessive-compulsive disorder, schizophrenia, in this whole spectrum, that it could be a subgroup of schizophrenia. Then from 9 Eylül University, again in 2007, and also together with Pamukkale University, their psychiatry departments are using these tests in a proper manner. Obsessive-compulsive disorder, for example, patients that were not depressive were considered, because accompanying depression can influence function. Another is that an intermediary group was made up for assessment, and on the right-hand column, as you can see, all the neuropsychological test scales were used in this assessment. And concerning the test performance, the more severe was the schizophrenia, and were assessed separately. And also those that were low were those that gave the best test points. In the spectrum, that it shifts to the psychotic area. From the perspective of neuropsychology, it would create a difference. And from Deniz Kale, Pamukkale University, the method was indeed very interesting. And insight or awareness, when that is unsatisfactory, weak insight or aware obsessive-compulsive groups was more near to the OCD schizophrenic group. And I believe this would be referred to. And naturally, between these 2 diseases, any separation or difference exists or not between the 2. We have to base this on a neuropsychological basis. And also, brain imaging is a method that is very widely used in area. Theoretically, in schizophrenia and OCD, that it uses the same these regions of the brain, but orbitofrontal cortex, we can see that in all of them, as parts of different loops, they are pretty much in the same regions. As we consider this in more detail, on left hand, we have the obsessive-compulsive disorder and the areas of the brain which is activated. From the perspective of schizophrenia, the importance of these areas, and from the caudal nucleus as concerning volume and activation. There are certain changes in schizophrenia. Orbitofrontal cortex, for example, shows an increase in volume, and also we see that perfusion is reduced at certain time in the thalamus, activity reduction. Schizophrenia, we see a decrease in cell number. In OCD, activation increases. In schizophrenia, hypofrontality, as we say, volume decrease. But still the same regions are apparently used. And this is a table where all the studies have been brought together. Activation studies we see in the column for OCD. There's activation increase in the related areas. On the right-hand side, in studies that show reduction of volume, with the exception of thalamus, there is volume decrease. But that the columns in the middle are sort of squeezed in between. It's a group for assessment or diagnosis where, based on images, schizophrenia, whether with OCD and without OCD, provides us information. There is, I had said that there was no data or concerning or proof on schizophrenia, but with the MR images, both in OCD patients and schizophrenic patients, one in anterior, in the other is the posterior, a shape deformity was observed in the thalamus. And actually, in the further analysis, the pulmonary nucleus is found in the dorsal part, and normally, although it has an asymmetric shape, there is a distortion of this asymmetric shape. And this indicates that besides the other brain parts, that thalamus should be analyzed in further detail. Treatments are part of our daily practice. We confront the patients for this purpose. Clozapine, olanzapine, risperidone. In the treatment of schizophrenic patients, we use these drugs. But for the OCD, there are some studies. In some of these, for example, sometimes the existing cases are exacerbated, but actually perhaps it's just the reverse. Some people argue that there's a reduction in OCD. And in a study carried out with clozapine on 50 schizophrenic patients, in 20% of the patients, new OCDs appeared, and clozapine in 20% shows a result of exacerbation. In a different approach, 198 schizophrenic patients, and different antipsychotics were used in treatment. And in the treatment of these, some had OCD become apparent. Clozapine, risperidone, olanzapine, during a treatment, they led to obsessive-compulsive disorders as antipsychotics that are administered. Well, we have determined the situation up to this point, but what should we do in that case? There are two studies for this purpose. The first for schizophrenic patients. In the first assessment, the Yale-Brown scale is used, and they were separated into three groups. At the start, even if it's a single point, they added the whole group, those over 10 or 16 points. And for the severity, that is, severity of OCD, in three groups, regardless of the severity. And risperidone was found to be more superior in reducing the OCD. Another study, an antipsychotic that is being used, was changed to amisulprate, whose activity mechanism is wholly different. And usually it's up to 30 milligrams per day. But when they went on to amisulpride, in 75% of this, more than 50% improvement was recognized according to the Brown scale. Because in some studies, even a 25 or 50% reduction in indications can be shown to say that the drug is effective. So usually the receptors that are blamed for this are the 5-HTA receptors. To the regard sense that the alcoholism is strong, then these antipsychotics, the D2 and 5-HT2A, the KI values for the drugs, for the compounds, and these values show their affinity to the corresponding receptors, and it's strong to the extent that these are lower. Clozapine, risperidone, for example, on the right hand side, and we can see that the receptor affinity is high. In the last two studies, if the results are interpreted, olanzapine and risperidone was compared. One is 0.2 activity, the other is 0.4, the other is 4. So olanzapine is much weaker than 5-HT2A, and perhaps this is how it can be explained that it can improve the disease. And in the transfer to amisulpride, we can observe that it has no activity. It's effective on D2-3 and obsessive compulsive disorders that perhaps it can show this is a good strategy. But these are the evaluations of two studies, and proof is not too expensive. In schizophrenia and OCD, dopaminergic and serotonergic etiology proof are overlapping. From the clinical perspective, in the process, they do have a lot of relations with each other. Obsessive compulsive indication is schizophrenia, and also in the treatment of schizophrenia till obsessive compulsive behavior comes out, whether there is such a subgroup in schizophrenia. When we consider the neuropsychological assessment and images, it appears that we have satisfactory data at hand to indicate this. Atypical antipsychotics are influencing the mechanism as well, and their activity mechanism is influential. So what should we do? At the start, 5-HT2A antagonist, if that is strong in schizophrenia, should we prefer drugs that are not such a character, or we would be doing something against the algorithm, or we could let things go as they are, and if there is obsessive compulsive indications, a weaker 5-HT2A antagonist should be selected. Perhaps there will be other conclusions of others.